Tiếp theo thì chúng ta sẽ nghe báo cáo của giáo sư Laurent Piero. Giáo sư Laurent Piero là giáo sư về điện quang can thiệp thần kinh rất nổi tiếng, hiện nay đang làm việc ở tại Trung tâm Điện quang can thiệp thần kinh Bệnh viện Ganh. Thì hôm nay do cái công tác thì giáo sư Laurent Piero đang công tác ở hội nghị ở bên Mỹ, cho nên là giáo sư có gửi bài qua cái bản ghi, thì xin kính mời trình chiếu cái bài báo cáo về cái tổng quan trong cái điều trị phình mạch não bằng web, tức là các cái lồng kim loại. Xin kính mời.
Good morning, everybody. Thank you for the very kind invitation. There was a development of the VIA microcatheter, which is dedicated to web placement. We have three sizes, 17, 27, and 33, according to the size of the web we want to place in the aneurysm sac. You know, web safety and web efficacy was widely evaluated in several series in Europe and US. And you see that there was no mortality in European series as well as in the US study. There was very low morbidity in European studies, 3%, 0.7% in the US study. Regarding efficacy, 1 year anatomical results in European study were complete aneurysm occlusion in 53% of cases and adequate occlusion in 79% of cases. Prevention of bleeding was effective, as demonstrated in Clarice, which is a study conducted in Europe and dedicated to ruptured aneurysm. There was no rebleeding at 1 year. Indication. So typical indications are wide neck bifurcation aneurysm, ICA terminus, ACOM, MCA, basilar artery at the top. Regarding the status, you can treat ruptured and recanalized aneurysm. And at the beginning, the recommendation was to treat aneurysm with an angle between the aneurysm and the parent artery less than 45 degrees. So typical example, ICA terminus, placement of a single layer web, end of the procedure, DSA at 1 year showing complete aneurysm occlusion, a wide neck ACOM, placement of the single layer web, control angiogram at the end of the procedure and at 1 year showing complete aneurysm occlusion, wide neck, very wide neck MC aneurysm, placement of the web. It is a control at 6 months and 1 year showing complete aneurysm occlusion. And finally, basilar artery, the top relatively large aneurysm, placement of a single layer web. You see the control at the end of the procedure and at 6 months you have a small neck remnant. Regarding the status, you can treat ruptured and canalized aneurysm. I show you an example of ruptured ACOM aneurysm. You see placement of a single layer web. You see the control angiogram at the end of the procedure, vasocity, and at 12 months, you have a complete aneurysm occlusion with some ectasia of the ACOM artery. Here, it's a ICA terminus aneurysm treated in 2002 with coils with a good results, but in 2016, you have a recanalization with a new new aneurysm sac that was treated with a single layer web. And you see the control angiogram at the end of the procedure and at 1 year showing a complete aneurysm occlusion. We have now extended indication, singularly distal wide neck bifurcation, pericallosal artery aneurysm, wide neck sidewall aneurysm, ICA, carotid ophthalmic PCOM, basilar artery, and you can also treat the aneurysm with an angle between the aneurysm and the parent artery greater than 45 degrees. So here it's an example of a pericallosal artery aneurysm treated with a SLS 21-7. You see the control angiogram at 6 months showing complete aneurysm occlusion. ICA carotid ophthalmic aneurysm, placement of a small web, and you see the control angiogram at the end of the procedure. And at 6 months, at 6 months, the aneurysm is completely occluded. Ruptured PCOM aneurysm, placement of the web, and it's a control angiogram at 1 year showing complete aneurysm occlusion. Here, again, PCOM aneurysm, you see that the angle between the ICA and the aneurysm is more or less 90 degrees. With the Web 17 system, we place a Web 17 SL6/3. You see that it's possible to do the treatment. Control angiogram at the end of the procedure, control angiogram at 1 year showing complete aneurysm occlusion. Finally, here, ICA aneurysm, you see that the ICA is coming from the neck. So you place the Web 17 SL3/2. It is a control angiogram at the end of the procedure, 6 months, 12 months, showing complete aneurysm occlusion, and the ICA is patent. Procedural modalities. You will use a triaxial technique. I will not describe it, but you know it. The microcatheter, you have to select the size of the via according to the size of the web you want to place. You have to shape the microcatheter, and you have to try to place the the via in the middle of the aneurysm sac if possible. Here you show the size of the microcatheter. For a web from 3 to 7, you will use a via 17. For a web 8 or 9, via 27. And web 10 and 11, via 33. Will you use Web SL or Web SLS? You will mostly use Web SL, let's say more or less 90% of cases, and you will use SLS if the neck is smaller than the aneurysm width, and if the aneurysm sac has a spherical shape. Web sizing, you have to oversize the web in the width, and you have to undersize the web in the height. So you will do measurement of the width and the height in 2 orthogonal directions. You will calculate the mean transverse diameter, and you will oversize the web of 1 millimeter according to the mean width. And you will decrease the height of at least 1 millimeter. So here an example, wide neck MC aneurysm, you see the measurement, you see that the mean width is 5.2. So the mean width is 5.2. You want to oversize the web of at least 1 millimeter. So you will have a 6 millimeter web. The minimum height is 6. So you will use a web of 5 millimeter in height. So you will use a 6/5. When you have correct sizing, the proximal marker has to be in the neck or better in the bifurcation of the aneurysm. I show you an example here, MC aneurysm, placement of the web, and you see the proximal marker is in the bifurcation. ICA terminus, same thing. You have the proximal marker in the bifurcation. Here another example, ACOM aneurysm, proximal marker is also in the bifurcation. What will happen in case of excessive oversizing? It will very rarely be associated with rupture, but it will singularly be associated with protrusion of the web device. MC aneurysm, we try to use a web SL 8/4. It's too big. You see that the proximal marker is not in the bifurcation, but in the A1 segment. So we decrease the size of the web to 8/3, and now the position is okay. What will happen in case of web undersizing? Either you will have no cure of the aneurysm, like in that case, you see placement of the small web, you see the proximal marker is not in the bifurcation. So it's a mistake that I have made. So what we have at 6 months, we have still the complete opacification of the aneurysm sac. At 12 months, the same. You see that we have contrast opacification in the web of the aneurysm sac. So what we were doing in that case, we were treating the remnant with a clip. And the treatment with a clip after a web placement is relatively easy to do, and it's a control angiogram after clipping. Also, if you undersize the web, you see it's a very wide neck MC aneurysm. We were using a 9x6 at the beginning, but it is protruding in the bifurcation. So we were using a 9x4, but you see with the 9x4 we have a neck remnant. And indeed, what will happen if you have a neck remnant? It really increases its size with time, 6 months, 12 months. Now we have an aneurysm sac, and we will be obliged to do a new treatment. Which kind of additional devices you can use? We can use the remodeling technique if needed. It means that you will inflate the balloon before web deployment, and the balloon will control the deployment of the web in the aneurysm sac and avoid protrusion in the bifurcation. I show you an example here. It's a case of Lawrence Pell and Christian Mialea. Thank you to them. You see it's a wide neck MC aneurysm, placement of the web without balloon. And we have a protrusion here, and we have a neck remnant at the upper part of the aneurysm sac. So we will inflate the balloon during placement of the web, and it will control the position of the web. And you see that now the position is quite good with the web completely inside the aneurysm sac. Additional coiling, we rarely use it. You see here it's a MCA aneurysm. We use a web SL8 by 3. The position is okay, but we have a daughter sac at the level of the neck that we cannot fill with web. So what we do, you see the daughter sac here, the vasosity. So what we do, we place a microcatheter between the web and the aneurysm wall, and we deploy some coils, and the final control angiogram is complete aneurysm occlusion. Sometimes it's due to the fact that we undersize the web. ICA terminus, placement of a dual layer web, it's a whole case. After detachment, aneurysm remnant. So what we do, we place some coils in the aneurysm sac. It is a control angiogram at the end of the procedure, 1 year control angiogram showing complete aneurysm occlusion. Additional stenting, we use it relatively often. We use it in 2 indications. If we have a very wide neck and we are not sure that we are able to protect the branches, in that case, we will deploy a stent at the end of the procedure after web placement. And also, we can use additional stenting in case of web protrusion. Here, an example, very wide neck MCA. You see that both MCA branches are coming from the neck. This branch has to be protected. What we do, we place a microcatheter in the aneurysm sac, another microcatheter in this branch to deploy the stent. We deploy the web, we deploy the stent, and it's a final control angiogram. The placement of the web is okay, and both branches are not stenotic. Here, another example, MCA aneurysm with a wide neck, placement of the web SL 9x6. And you see the control angiogram shows that there is a protrusion in the upper branch. So what we do in that case, we place the stents. You see the placement, the vasosity. You see the placement, so we reopen completely the upper branch, and we have now a good placement of the web in the aneurysm sac, and it is a final control angiogram with no stenosis on both bifurcation branches. Additional flow diverter. I am not too much in favor of combining flow diverter and web because the mechanism of action is more or less the same, except in some relatively rare case. You see it is what we call segmental disease with several aneurysms in the same arterial segment. We want to place a flow diverter here, but I want to place something in the aneurysm sac. It's not possible to place coil because the one segment is coming from the branch, from the aneurysm sac, sorry. So we place the web in the aneurysm sac, we place the flow diverter in the ICA, and it's a final control angiogram. And you see the control angiogram at 6 months show complete occlusion of this aneurysm with the web and the flow diverter. Finally, management of complication. you see here the frequency of complication in the European studies. You see that the rate of emerging complication is 1.8% without clinical worsening in all complications. The rate of thromboembolic complication is 14%, with permanent deficit is only 3% of patients. What we do in case of intraoperative rupture, the mechanism can be parent artery perforation or aneurysm perforation during the placement of the microcatheter or during the deployment of the web, singularly at the beginning of the deployment of the web, because at the beginning of the deployment, the web is relatively stiff. What you will do, stop heparin, protamine, inflate a balloon if you have one, deployment of the web. An example here, wide neck MCA. During the placement of the web, what we have extravasation of contrast, so web, so aneurysm rupture. So what we do, we inflate the balloon, we deploy the web, and 4 minutes after the rupture, the web is deployed and the bleeding, as you can see here, is completely stopped. It is XPRCT at the end of the procedure with some contrast media in the subarachnoid space, hitting the susceptibility weighted images 24 hours later, showing some clot in the sylvian fissure. And the clinical status was completely okay. Intraoperative thromboembolic complications, they are relatively often related to web protrusion. It can also occur due to migration of clot from inside the device, but it's relatively rare. What you will do to manage this, in case of protrusion, you will use ballooning or stenting, I was showing before. In case of thrombus formation, you will use chemical thrombectomy, anti-GB2B3A. You will try to avoid mechanical thrombectomy because you can change the position of the web if you use the stent in front of the web. Here to show you some management of complication, basilar artery, aneurysm, ruptured, placement of the web. You see the placement of a single layer web. It is the control before detachment, after detachment, 10 minutes after detachment, we are losing the P1 segment, and 30 minutes after detachment, we are losing the basilar artery. So what we are doing, because it's a ruptured aneurysm, we are ballooning the right P1 on the basilar artery. It is the final DSA, finally, we have the reopening of the P1 segment of the left side, and it sees MRI at 24 hours, showing some spot in the cerebellum. And finally, the patient was okay. It is a DSA at 6 months, 12 months, showing good aneurysm occlusion. Here, another example, unruptured basilar tip aneurysm. We place the web, but the web is protruding. It is the smallest web we had at that time. It is protruding, unfortunately. So what we do, we place a web in the left P1 and the upper part of the basilar artery. It is the final control angiogram, it's the MRI at 24 hours, and finally, there was no clinical worsening. Thank you for your attention.